So it is intrapartum fetal monitoring is the topic, right? So intrapartum fetal monitoring, what we do normally is we do intermittent fetal heart rate monitoring as well as CTGs, right? So these are the two methods that we do intrapartum fetal monitoring. So why do we need intrapartum fetal monitoring? We need intrapartum fetal monitoring because this was the most difficult journey that we had. The normal delivery. It was the most difficult journey we had to undergo. Huge risks involved, life and death matter, but we went. Luckily, we didn't know about it. So these babies are in huge risk from time they go into labor to the time of delivery. Even today, I came across a emergency cesarean section where there were 3 cord round necks with a lot of fetal distress involved. So it's always very risky procedure, risky journey. So as obstetricians, it's our duty to reduce this risk. It's our duty to reduce the risk to the mother as well as the baby during their normal labor and delivery. So for that, especially for the baby, we have these different methods invented to reduce the risk. One of them is the monitoring of the fetal well-being or fetal try to detect fetal acidosis. Of that, CTG comes the main thing. So if you talk about fetal hypoxia is a normal thing. Without fetal hypoxia, fetal can't deliver. I mean, we all know when we knock off the blood supply to the baby during contraction, hypoxia develops. But that doesn't mean the baby will be bad all the time. There's lactic acid formation, all right, but the lactic acid will ultimately result in a little bit of metabolic acidosis. But that metabolic acidosis is buffered by our buffering systems like the bicarbonate buffer, the hemoglobin, the proteins, and so on. So the baby does not become acidotic even though the baby is hypoxic. So hypoxia is a very common thing in labor, but acidosis is a very uncommon thing because of the buffer system. But if we allow to continuously bombard this child with the problems of acidosis, then of course the buffers will be depleted. And when the buffers are depleted, there is increase in hydrogen ions and the buffers are not there. And that will now start disrupting the endocrine systems and tissues, and that will result in a fetal acidosis, and that will make the pH change less than 7 and the base deficit more than 12, ultimately resulting in a fetal acidosis or fetal resulting in fetal ischemic, hypoxic ischemic encephalopathy, right? So that is what we have to understand. So for that, to prevent that, we have different methods of monitoring the fetus. First thing is what we do in the labor ward. We do this thing called intermittent auscultation. This can be done through a pinard or a handheld Doppler, right? So intermittent auscultation is done every 30 minutes after contraction in the first stage latent phase, every 15 minutes after contraction in the active phase, and every 10 minutes in the passive phase of the second stage, and every 5 minutes in the active phase of the second stage, right? So we do intermittent fetal heart rate auscultation. Then we do the CTG. CTG we do every every 4 hours. We normally in the labor we do a CTG trace that is about 20 to 30 minutes long, right? And then we try to detect anything abnormal. If the woman is at high risk, we do continuous fetal heart rate monitoring. So whatever said and done, all these 3 methods can be done. In Sri Lanka, we don't have a recording system for continuous fetal heart rate monitoring, but when there's high risk pregnancy, we will connect to the CTG and we will try to monitor the baby through a CTG. But if there's abnormality going on, then we'll start the record. That's what we do in Sri Lanka because we don't have that much of paper to do a recording for continuous fetal heart rate monitoring. Very important that we do the fetal heart rate monitoring in a correct way because it's a legal document. It should be legitimate. So it should be routinely audited and see whether everything is done correctly. So the following things were recommended by FIGO about that. So it should be lateral recumbent, half sitting, half upright positions are preferable. You can use a telemetry if you want. The patient's name, the hospital number, the date of birth, and the date and time of recording, pulse rate, temperature should be always be checked and recorded before starting the thing. So when you are in audit, if I give you a CTG, if these things are not there, you should be able to tell these things has to be recorded, but it's not there. The start time and the finish time should be recorded. the tracing speed should be 1 centimeter a minute, right? And the heart rate should be auscultated by the spinal stethoscope or the handheld Doppler before you put the CTG probe into the maternal tummy. It's very important that you don't probe it with the CTG probe and find it and then start recording, because CTG probe might even connect the maternal pulse because it's a very big probe. You have to always go by the pinard or the handheld monitor. All the events that you do during the labor should be recorded in the CTG, including vaginal examination, fetal scalp blood sampling, if the epidural is put, if epidural top-up is done, everything has to be recorded, right? And always it should be a legitimate document where a staff person has seen it and signed it and told what to do with it. If it is not there, it is not a legal document. Anybody can take a CTG. If no one has seen it, it is useless. So someone has to see and sign that one and tell what to do with that trace. Okay. So what's the CTG? It's a method of fetal heart rate monitoring where the fetal heart rate and the uterine contractions are recorded simultaneously in a paper. That's what we do. So if you always have seen CTGs, and in a CTG, it's like ECG. You have to look into 4 areas, right? You have to look at about the baseline heart rate. You have to look at about the baseline variability. You have to talk about the accelerations and the decelerations. Those are the 4 areas that you have to concentrate. So the baseline heart rate. So what are the baseline heart rate? This means the level of the most horizontal and less oscillatory fragments of the fetal heart rate tracing. Most ones that goes, which cuts the line, is the basic baseline fetal heart rate. Normally, you take about 10 minute strip and you draw a line and see what is the line that is most cut, and then you take it, right? So you don't take areas where there's accelerations and decelerations as the baseline heart rate. So the normal baseline is about 110 to 160. Anything above that is tachycardia, and anything below that is bradycardia, right? So many reasons can be there for tachycardia and bradycardia, mainly maternal pyrexia, infections, all these things can cause tachycardia, whereas hypoxia or hypothermia can cause bradycardia. What you have to understand is this trace. You see, now I take about 10 minutes area and I like to draw a line when there's not much of accelerations or deceleration. Then I come across which is most cut. You can see it is around 140. Give me 1 minute. Hello? Oh. 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 ඒ ක්ලිනික් එකම ගත්තත් කමක් නෑ ඕවා නැතුව. ඕවා ටිකක් ඊට වඩා ටිකක් වැඩිපුර තියෙන එච්චරයි. ඒව එච්චර අත්‍යවශ්‍යත් නෑ. ආයෙත් ගන්නෙ නෑ. ඒතකොට අරවම ඕනේ නෑ. අරවා ඕනනම් ගන්න. ඔය පොඩි ඩෝස් වල තියෙනවා. ඒ දෙක රැට කැල්ටමින් එකයි අනිත් එක උදේට. ඒ දෙක උදේට. ඒක ඕනේ නෑ. ඕනේ. ඕටි ඔක්කොම තියෙනවා. Okay. So you take the baseline heart rate where the line is mostly cut, right? Then you have the variability. Second thing is the variability. It refers to the oscillations of the fetal heart rate signal up and down. You take the signal in about 1 minute segment. Normal is about 5 to 25. Reduced is less than 5, but it should be at least more than 50 minutes, because less than 50 minutes might be a normal variability, because the baby might be sleeping and then you get a reduced variability. That's why. But if there are decelerations, even a 3-minute gap is significant if you have reduced variability. Decelerations එක variability අඩු වෙන්න තියෙන එක risky වැඩි. ඒකයි කියන්නේ. So you can see this variability. You see, you take a 1 minute area, you see it goes up, goes down, goes up, goes down. So what goes up and comes down is goes up here, comes down. So this is the variability. Goes up, comes down. That's the variability. So goes up, comes down. So you have to see the whole Z mark, what goes up and what comes down. Both together is the variability. Not only going up part or the going down part, both together, right? Both together. Right. So you can see this is a reduced variability stress. See? Basically, it doesn't go up and down. When you add up and down part, both it is less than 5. This one is a variability reduced trace. You see, the variability is very much reduced, where you can see my cursor very much reduced. but there is decelerations as well. Even 3 minutes of this race is dangerous. This has gone about 1 hour, I don't know, but even 3 minutes is dangerous, right? And then you can have the increased variability, more than 25. You can see this is more than 25, totally going up and down, right? Then it is called a saltatory pattern, and that is also abnormal. It might also tell you about something like a very rapidly developing hypoxia. Then you have accelerations. Accelerations are increased in fetal heart rate for more than 15 beats per minute, lasting for more than 15 seconds, right? Having accelerations is a very reassuring thing. Normally, in a normal trace, you will have some accelerations. If you don't have acceleration, that doesn't mean the baby is abnormal or baby is in distress, but it gives you a little bit of alarming marks. That's all, right? So accelerations are good, but not essential. When you have accelerations, always see whether there are contractions also coinciding with accelerations. Then, of course, you have to always think a little bit carefully whether these accelerations are due to maternal accelerations and you are taking maternal pulse. Normally, with a contraction, the logic is the baby's heart rate should go down rather than go up, right? Then you have decelerations. So decelerations are of 3 types. You have early decelerations, variable decelerations, and late decelerations. So you have to know all 3. The commonest is variable deceleration. So if someone asks you about a deceleration and you don't know all about it, you say variable. 80% of the time you will be correct. So I gave you a lucky guess, right? But early, late, variable, and late. Early decelerations are very rare, mind you. Variable, late are more common. Variable is 80%. Most of the rest is late. Early decelerations but by definition, early deceleration starts with the contraction and ends with the contraction, and they are a mirror image of the contractions. Right? They are like a mirror image, and they are very shallow, and they are very short lasting, and they recover very fast, right? So if you want to memorize it, they are a mirror image of the contractions. They are very shallow, short lasting, and they are very rapid recovery. And the last thing is they are having a very good variability inside the deceleration. They don't have flat traces, right? So they are rarely only associated with fetal compromise. They are not very dangerous normally. It happens due to head compression, due to compression, and that will cause a vagal nerve stimulation, and you get these decelerations, right? So these are early decelerations. You see, very shallow, just goes up, comes down, goes up, goes down, comes up, goes down, comes up. Always a mirror image of the contractions, right? So, and there's a good variability in this trace as well. Okay, then you have the variable decelerations. These are also V-shaped, like the early decelerations. They have a rapid drop and a rapid recovery, and have a good variability inside the deceleration. The very particular thing about these decelerations is there's an upstroke, downstroke, upstroke, and a downstroke. So it's like a very typical shape that you have. They are also occurring due to head compression and corp compression, and normally rarely associated with fetal compromise, right? So if I show you some variable decelerations, you can see there's one here. Now this is a typical variable deceleration. Goes up, comes down, goes up, comes down, right? But there are these atypical features of variable decelerations, like a late component. See, shouldering upstroke, downstroke, dangerous. Then if there's exaggerated shouldering, problem. Delayed recovery variable deceleration, right? And then if there is loss of variability in the deceleration, that's also bad. Now, the typical feature of variable deceleration is, now I told you early decelerations are always coinciding with the contraction. Late decelerations, I will discuss later, they will be coinciding, they will be occurring just after a contraction. But the variable decelerations just not have a relationship. So there will be decelerations occurring without a contraction. There will be decelerations occurring with the contraction. There will be a contraction without any deceleration, like that. So variable deceleration by every means are very variable. It might be associated with the deceleration or not associated with the deceleration. That's why they call it variable, right? So variable decelerations are not having any relationship with the contractions. Remember that. Then you have the late decelerations. Now the late decelerations are very typical that they occur late. They occur after the contraction. Right? They occur after the contraction, about 30 seconds after the contraction. Now, very important thing about late decelerations are that they are normally not V-shaped. Both of the decelerations we talked earlier were V-shaped. These decelerations are U-shaped. They have a slow recovery, slow going down, slow recovery, and they are normally having reduced variability in the deceleration, right? And normally late decelerations are 50% of the time associated with fetal acidosis, right? If you have late decelerations recurrently happening, always be careful whether there is a fetal acidosis going on. So these are late decelerations. I show you why. See, the acceleration, the contraction, deceleration. Contraction method deceleration. Contraction method deceleration. Contraction method deceleration. Contraction deceleration. So late decelerations always happen after a contraction. These are also, if you look closely, are late decelerations. You see, this is contraction, this is deceleration, this is contraction, deceleration, contraction, deceleration, contraction, deceleration. Right? Then you have this thing called prolonged deceleration, single prolonged deceleration. So they are decelerations that last for more than 3 minutes. So that is single prolonged deceleration. They are very high risk. Normally, if it exceeds 5 minutes, that indicates that there's a problem. And you have to rapidly deliver this child because there's acutely developing hypoxia and need to deliver this child as soon as possible. If the cervix is not fully dilated and the baby is not even enough to be delivered, you rush to the theater with the patient and deliver this child as soon as possible. This is a typical picture of prolonged single prolonged deceleration. You see it goes down, stays there, stays there, stays there, stays there, and stays there. It doesn't come up. Then you have this sinusoidal pattern. That something that you have to understand is it's like a sawtooth. Sawtooth කියලා කියන්නේ කීයතේ දත් වගේ. නැත්තම් මේ ශාකයේ දත් ටික වගේ. Sawtooth වගේ. උල්ලු. උඩට යනවා පල්ලෙහාට යනවා උඩට යනවා පල්ලෙහාට යනවා. It is not the variability I am talking about. It is the cycle. Right? You see, now if you take this trace, මේක බැලුවොත් ඔයාලට පේනවා මේ දෙවෙනි එක බලන්න පළවෙනි එක ටිකක් ක්ලියර් මාදියට උඩට කරලා තියෙන්නේ. but දෙවෙනි එක බැලුවොත් you see the variability is very low. See, variability is very low. I think students you can understand the variability is very low, but the trace just goes up and down like a sawtooth. So you must not mistake this that the variability is good. This is not a variability. Variability ना मैं इधर लगिंग मैं उधर पाल है यार मैं कभी trace से क्या मतलब मैं उधर पाल है trace से क्या heartbeat के नहीं trace से क्या मतलब मैं उधर पाल है. So this is called a sinusoidal pattern. Right? This is very risky. That indicates the baby is having anemia. Most probably there's an abruption or something going on. That's why the baby is losing blood. Right? So that's a little bit of a risky situation that you come across. Okay. Pseudosinusoidal pattern. There's a thing called the pseudosinusoidal pattern. I'll tell you what it is. It is that it interchanges with the sinusoidal pattern. Normal tracing या किरे टिके लागे sinusoidal लेना. Normal लेना sinusoidal लेना. එහෙම වුණාම අපි කියන pseudosinusoidal කියලා. ඒක එච්චර ප්‍රශ්නයක් නෑ. ඒක තාම සකින් හින්දා ඒ වගේ වෙන physiological දේවල් හින්දා වෙන මිසක hypoxia හින්දා නම් නෙවෙයි. Then you have this thing called fetal behavioral state. Fetal behavioral state කියලා කියන්නේ now the baby is also human. So the baby will have sleeping time, baby will have playing time, baby will have a normal time. ඔය උඩ බලාගෙන ඉන්න වෙලාවක් තියෙනවා. හොඳට සෙල්ලම් කරන වෙලාවල් තියෙනවා. ඒත් එක්කම තියෙනවා හොඳටම නිදියගෙන ඉන්න වෙලාව. එතකොට අපි CTG එකක් දානකොට අපි දන්නේ නැහැ මේ ළමයා කොයි වෙලාවෙද ඉන්නේ. We don't know which stage the baby is. So that's why we have to wait at least 50 minutes to say that the baby's baseline heart rate is reduced. Because normally the baby does not sleep more than for 50 minutes. That's why. Okay? Then when the baby is awake and playing, then you see lot of accelerations and no baseline. Baseline එකට එන්න දෙන්න බබා හොඳටම heart එක හො ගහලා වැඩ යනවා. So you can see a trace like this. Now this is called the active wakefulness. Now in this active wakefulness state you can see the heart rate is මේක නිකම්ම බලපු ගමන් තේරෙන්නේ tachycardia එකක් යනවා 180ට ඒ අතරතුර deceleration යනවා හො ගහලා. But actually what is happening is the baseline heart rate is somewhere around 140 and there are so many accelerations here. And because of that you are seeing these accelerations as the baseline heart rate and you can see the baseline heart rate as decelerations. So to overcome this, when you have a trace like this, best things to do is you have to wait for about 40 minutes to see whether it settles. Now you see how do you know that this is not decelerations is you can see the variability in this trace is really good. I mean මෙච්චර හොඳ variability එකක් තියෙන trace එක බබා acidotic වෙලා decelerations පිට එන්න විදිහක් නැහැනේ. So when you think around it you will understand no this can't be a very bad baby. So something else is wrong. Then what is wrong when you search? It is actually the baby had been playing. That's why you see this trace. Then you have to know something about tachysystole. Tachysystole is overwhelmingly increased contractions. Normally we expect 3 to 5 contractions per 10 minutes. If it is more than that, then we call tachysystole, and that is a dangerous situation which can lead to fetal acidosis and death because of severe hypoxia developing within a very rapid time. The baby does not have time to regain the blood flow that is lost during the contraction. Okay, now that we have learnt about all the variants in the CTG, it is now time to learn how to interpret a CTG. So we normally interpret a CTG in 3 types. We say it is suspicious, pathological, and normal, suspicious, and pathological. Right? That's how we divide the CTG. Right? So this is the way you change categorize the CTG: suspicious, normal, and pathological. Now it is very difficult to memorize all these things. I know. I will tell you a very easy method to memorize it. Okay. Remember what is normal and remember what is pathological. Then you know what is suspicious. No. So baseline heart rate normal is 110 to 160. Pathological is less than 100. So you know now what is suspicious. Anything less than 100, anything less than 100 is pathological. So 110 to 100 is suspicious, pathological. Sorry, suspicious. And anything more than 160 is pathological. Sorry, anything more than so less than 100 is only pathological. So anything more than 160 is not pathological, it is suspicious. මොකද fever aroma hypoxia නැතු වෙන condition හින්දා 160ට වැඩි වෙන්න පුළුවන්. ඒකින්ද අපි 160ට වැඩිව අපි we have to really see what is wrong. It is not pathological all the time. What is pathological is less than 100. That's all. So remember what is normal 110 to 160. What is pathological less than 100. That's all. Everything else is suspicious. Then variability again 5 to 25 is normal. Reduced variability for more than 50 minutes is pathological. Increased variability of saltatory pattern is pathological. Sinusoidal pattern is pathological. Other than that, everything is suspicious. Reduced variability for 20 minutes is suspicious, not pathological. Then decelerations, ideally in a normal trace, you don't have to have any repetitive decelerations. Pathological is only these two. If you have single prolonged decelerations, if you have late decelerations, then of course it is pathological. Anything else is suspicious. So in other words, early decelerations and variable decelerations are suspicious, not pathological. Then you know what is baseline variability, baseline heart rate, and baseline decelerations. So deceleration. So you know what are normal things, you know what are suspicious things, you know what are pathological. So if you get a trace and everything is normal in that trace, then you say the probability of hypoxia is very low. So you don't do any intervention. If you have at least one suspicious thing, then it becomes a suspicious trace. And there you say there's a low probability of hypoxia. In a low probability of hypoxia trace, you will not have any pathological features. Okay, only suspicious feature. Not more than one. If you have two suspicious things, still it goes down to pathological. Right. So here you have to see whether you can correct something that is abnormal and try to mend it. If not, you might try to do and deliver. Pathological, anything pathological is problematic. If the 3D stage is pathological, if you have facilities, you have to go for a fetal scalp blood sampling. You have to see whether you can rectify the problem. And if you can't rectify the problem, you have to go for a fetal scalp blood sampling. If you don't have facilities for fetal blood sampling, then you might have to decide on delivery of the baby. If it is fully dilated, you might think about the instrument. If it is not fully dilated, you might have to think about cesarean section. Right. So last slide I have not put here actually is about intrauterine resuscitation. What will you do if the CTG trace is pathological? What you have to do is, even if you have to do think is, what will you do if you see someone all of a sudden fall in the road? You are coming to your faculty and in the bus stand you see a nice girl all of a sudden fainting due to some fainting attack. Then ideally what you do is you go and resuscitate that person. You go and resuscitate and try to revive her, make her live another day. So that's the same thing you have to do for this baby also. The baby's heart rate is dropping and there are suspicious features, so pathological features. You can't look up and go. You go and try to resuscitate this baby. How do you do it? You try to turn the mother to a side or reposition the mother. Maybe put the sit up the mother, right? Try to reposition so that the blood supply will increase. If she's dehydrated, if she's in the labor room for a long time, that might cause hypoxia, dehydration. So try to hydrate her. 2 pints of normal cell and fast. If she is having a syntodrip and that is causing tachysystole and hypoxia, stop the syntodrip as possible. Stop it. Still, the contractions are very violent. You can give a tocolytic. In Sri Lanka, we don't have much of tocolytics. What we have is only sublingual GT8 spray. But in the other countries, you have subcutaneous terbinafine. It's a beta blocker, beta stimulant that will stimulate the relaxation of the uterus. You give 0.25 milligrams subcutaneous, right? Then what else can you do? You can what else? Okay, you can always repositioning, giving fluids, reducing the contractions, and giving a tocolytic. Yeah, only those things you can do. Now they say don't give oxygen. Those days we used to give oxygen also. That might even reduce. It might reduce the blood flow more. So not to give oxygen unless the mother is hypoxic. Try to see whether the CTG becomes okay. If not, you have to expedite. Okay. Good. Any questions about CTG? No. Okay, you have to go and get a small piece of CTG trace or make a photo of a CTG trace from your board and paste it and write down what I have told. This presentation I will send to the department. You can ask it from the department when they are there, right? Okay, then I'll finish for now. Okay.
Thank you, sir.
Okay.
Thank you, sir.
Okay.
Thank
see
you, sir.
Yeah, I will send the presentation to the department.